Hello, hello, hello. Welcome to those of you who are joining. We are so happy to have you. Good day to everyone and happy Friday. We made it through this week. I am Dr. Ulysses Burley, the founder of UBtheCURE, a Chicago-based organization that operates at the intersection of faith, health, and human rights. I am a proud recipient of the inaugural NMQF 40 Under 40 Leaders in Minority Health Award, and currently serve on the National Minority Quality Forum Advisory Board. It is my pleasure to moderate today's webinar in observance of June as Men's Health Awareness Month. This month is all about encouraging men to take better care of our bodies by eating right, exercising, and working to prevent disease, which requires intentional engagement with the healthcare system, something that continues to be a growing edge for men. We know that men have an overall lower life expectancy than women. And when you stratify the data by race and socioeconomic status, Black and brown men die even earlier. Men are also more likely to be diagnosed with a chronic illness at an earlier age than women. This disparity among men is in part due to our reluctance to seek medical attention. And when we finally do, it's usually too late. So I am pleased to be joined today by Dr. Glenn McWilliams, who will help us unpack the various disparities in health among men, and particularly Black men, and help us get to solutions for overcoming these disparities. Dr. Glenn McWilliams is Chief of Robotic Surgery at the James J. Peters Veterans Affairs Medical Center and an Assistant Clinical Professor of Urology at Columbia University and Mount Sinai School of Medicine. Dr. McWilliams is a graduate of Columbia University College of Physicians and Surgeons and Urology Residency Training Program and completed a fellowship in urologic oncology at the National Cancer Institute. He is a retired lieutenant commander in the United States Public Health Service. Dr. Williams is an active member of a number of professional societies, including the American Urological Association, the R. Frank Jones Urologic Society, and the Society of Urologic Oncology. And he currently serves as the president of the Manhattan Central Medical Society. Dr. McWilliams has extensive experience in minimally invasive and robotic surgery and developed the first robotic surgery program within the Veterans Integrated Systems Network. Dr. McWilliams is an investigator on multiple research projects involving urologic oncology and healthcare disparities. We are pleased to have him with us today to share his expertise on various urologic disparities among men. Dr. McWilliams, welcome.
Thank you for having me. I'm excited to be here.
Thank you, thank you, thank you. So tell us a little bit about your work and specifically about the urologic disorders that disproportionately impact men, but even more so Black men.
Okay, well, I'll give you even a little bit of background just about myself, which is, I think, pertinent. I am a first-generation American born to immigrant parents from Jamaica and Trinidad. And I grew up in New York City, born in one of the more somewhat segregated boroughs of Staten Island, but then spent the majority of life now in Manhattan. I went to Cornell University as an undergrad, and then, as you mentioned, I went to Columbia and then did my fellowship in the National Cancer Institute. But I bring this up just because it was family influences that encouraged me to pursue my scientific accomplishments and pursue medicine. And I saw also that even as a college student and then through medical school, there's a need to relay information to our community because there's a lack of it. And even some people that actually regularly go to doctors, if they're not necessarily culturally sensitive or have the time, do they convey the proper messaging? And sometimes that can be onerous and intimidating to patients. A lot of patients, particularly minority patients, don't want to bother doctors. Like my family tells me that. As I kind of mentioned before we got on this, I'm dealing with something right now. But even as a urologist, I get questions about everything in healthcare, and from dermatological conditions to urology. So it's just important to be a member of the community. The number of Black physicians is decreasing, unfortunately, in this country, Black and brown. It doesn't represent what the population is. Both Black, Hispanic, or Latinx is not up to the 13 or 14 or 15% that represents in the country. And there is evidence that shows that people that are culturally sensitive, whether you're in the same community or not, that deliver healthcare often deliver better healthcare, and the patients do better. And ironically, actually, it works even in the way that if you're sensitive to all communities, which oftentimes the most disenfranchised ones might be the Black and brown ones, then you're going to obviously be sensitive to the majority of the community as well. But the converse is not true, that if you're happen to be a part of the majority of society, then sometimes you're just not, the message is not conveyed as well, even though the training might be as good or even better in some cases. So anyway, that brought me into my interest in surgical things, because I wanted to be a surgeon, as a doctor, and urology is one of those fields. Urology happens to deal with, it's called the genitourinary medicine, and it deals with everything from the genitals, which is the reproductive and sex organs in a man and even a woman, although with more of the female organs and things like that, a gynecologist might deal with that. But all the urinary systems in both men and women. And that leads from the kidneys, the tubes that connect your kidneys to your bladder, the ureter, your bladder itself, the tube that goes from your bladder out, which is called your urethra. And then in a man, his penis, and a woman, their introitus. And all these different areas that are affected. We also deal with the adrenal glands, which actually help deal with people's metabolism and different things. So there's a lot of reasons why urologists are involved. And actually, we actually do a lot of primary care work, because many things and manifestations in urology, it's kind of what came first, the chicken or the egg. So like if somebody has high blood pressure, it could actually be something urological that might be causing that. And then also somebody has high blood pressure, as they get treated for it and they're given water pills, and people are going to the bathroom all the time to get that water off their body. It's not frankly a urological condition, but they'll often be sent to a urologist and being told that they have urinary issues, which is not really the problem. They're taking a water pill, so they go into the bathroom a lot. In terms of men's health, and this month, and this webinar that we're doing, and then I'll let you chime in with questions and stuff, is I happen to do urologic oncology. So I deal with a lot of prostate cancer, but I also deal with bladder, penile cancer, testicular cancer, adrenal cancer, ureteral cancer. And oftentimes Black and brown patients wait until things become symptomatic, painful, or their bodies actually even having sequela, such as weight loss or major problems, before they'll show up. There's too few people that do preventive medicine and just well checkups, because even if something starts small, it's always easier to deal with it on a smaller level. So we focus on the biggest healthcare disparity, and the biggest cancer disparity in the entire world actually happens to be in prostate cancer. And that Black men are more highly affected by prostate cancer than their peers. And that's, in all cancers across the board, that disparity has existed and persists. And it's not necessarily that race is a biologic, but race is more, can be a social determinant of health, which means that sometimes it's just a matter of Black patients showing up. It's not that the disease necessarily might be worse in us, but if you show up, you're screened, it's picked up early, and it's treated, then we do just as well as any other population. So one of the first steps in all of this is go for your well checkups, and definitely if anything's bothering you, then go see a specialist. And one other thing too, if for any reason you have a family history of any of these things, particularly prostate cancer, then your being Black and having a family history then puts you even at a higher fold, like maybe 8-fold chance of having the disease and also having a more aggressive form. One of the other things I deal with is erectile dysfunction. And I bring that up because it somewhat even ties into even the prostate cancer. So some of the treatments that we do for prostate cancer involve obviously treating the prostate, and there's nerve endings that help a person get an erection. So a lot of men don't want to even go get their prostate checked, even if they're not really fearful about prostate cancer, because they hear it has something to do with their ability and may cause problems with them getting an erection. But the reverse is somewhat true, that sometimes an enlarged prostate and urinary symptoms that are keeping somebody up all night, making you more fatigued. If you're having like sleep apnea too, if that's keeping you up, and also having different changes in your pituitary axis in your brain and hypothalamus, it can make you urinate more. Those things can affect your ability, your testosterone levels, and then also just fatigue itself caused by that stuff don't help in your circulation and also your mental and endocrinological abilities to actually get an erection. So, something like sleep, everyone says, it's almost an overheard thing that you should get more sleep. But if you tie it into something that has a benefit or somebody's motivated to maybe make an improvement, sleep, blood pressure control, salt and things, and especially diabetic control and glucose and things, all of those things, if you're not controlling them, can cause erectile dysfunction. So it's not just cancer and your prostate, but other things as well. So there's other things I do as well, but I'll let you get in some questions and let you moderate more.
Thank you for giving us that foundation for what I think will be a very fruitful conversation. You began to talk a bit about the anatomy of the prostate. Tell us a little bit more about the prostate as an organ, its function, its ability to continue to grow with men as we age, and why it's such an important organ, and why everybody needs to be mindful of not just prostate cancer, but benign prostate hyperplasia as we grow older, just by the near nature of the organ itself.
Right. So the prostate is usually described as a walnut-shaped or sized organ. It's small, and as I said, like almost a walnut size, and it sits between the bladder and your urethra. So it's the final passageway or gateway or tunnel that the urine has to pass through in order to get out of your body in a man. Its function is it creates certain types of proteins that actually help liquefy sperm, so that when in your ejaculate, it helps the sperm become more active, be able to swim, and also creates an environment that makes the vaginal canal, because it has to be introduced into a vagina in order to fertilize an egg in a woman. That can be an acidic environment. So the semen that the prostate helps create helps protect some of the sperm, also gives it energy so that it will be able to swim. It's very aggressive and strong swimmers. If you don't have you could still, the sperm itself is actually coming from your testicles, which is emptied out into the prostate. It mixes with the fluid from the prostate, and that's what goes on into a vaginal canal, and hopefully to connect with an egg to cause conception. It's not a vital organ. You can live without your prostate. It will create fertility issues, as somewhat alluding to what I had just described. But even by that itself, if a prostate's removed, you can actually get sperm from a testicle and do in vitro fertilization with an egg from a woman and actually still have children. So the prostate is actually not the thing that causes sperm. It actually is just it's a conduit where it empties into, and it helps the sperm exist and last. As you mentioned, it starts out small, and in about 50% of men, it enlarges as you get older. And sometimes just the size itself is not necessarily the issue, but the way it's growing. So you could have a big prostate. So a normal size is what we use somewhat interchangeably as cubic centimeters or even grams. So the normal size might be about 15 to 20, but there's men that are 10 times that size, 300 gram or 300 cc prostate, and they have no urinary symptoms. But then there's somebody with 2 or 3 times fold the size, but because it's growing in and impinging or pressing on the urethra, the tube that you pee through, it's blocking the urine from getting out, and that can cause problems. And as you alluded to too, BPH or benign prostatic hyperplasia is more common than the prostate cancer and actually causes more issues and problems. And that's usually what leads most men. That's what you'll get symptoms from. That's why you'll have issues going to the bathroom too much, getting up at night, having to strain to go. And some men strain so hard that actually they develop inguinal hernias. So one of the main things that goes as people go find out they have a hernia, they don't even know that they've been straining for a long time to get their urine out, and that's actually helping create more of a defective hernia in their body. So we work with general surgeons in order to treat the prostate before they'll get their hernia surgery, because the hernia surgery won't repair too well, or it'll come back if they're still causing the same type of strenuous activity.
Thank you for that. So in terms of screening benchmarks, I just turned 40 this year. My maternal grandfather is a prostate cancer survivor. So I'm aware of my family history, and at the recommendation of my primary care physician, last year at my 39th birthday, I got my first PSA test and was happy to report that it was normal. I just had my annual for year 40, and again, did a PSA test, it was normal. Talk to us a bit about when men should be getting screened for prostate cancer based on race and ethnicity and family history.
Right. So for the majority of population, which happens to be more white, it's 50 years of age. But if you have a first degree relative on, particularly on the paternal side, and that happens to deal with prostate cancer, but also we're finding out there's linkages in some genetics with women with breast cancer. So if you have a maternal relative who has breast cancer, now we're realizing too that may put you in a higher risk too. So breast or prostate cancer in the family, you should start getting screened at 40. And then the other risk factor in our thing for today is actually for minority patients, particularly Blacks, at 40 years of age, you should at least go get your first PSA.
So I'm right on track, because my mother passed from breast cancer. Her mother died from breast cancer. And my grandfather is a prostate cancer survivor. And I had my first PSA test at 39. Could you talk to us a bit about the various indicators for prostate cancer, like the PSA test and other diagnostics?
Yeah, so what happens is we all should have, hopefully, primary care doctors, right? And they screen. Primary care doctors have the hardest job of all of us. Some of us who are specialists, we take all the glory, and but imagine someone sitting down with someone and having to go through every organ, system, and body with them. So there's usually a routine number of tests that they'll do. And that varies from year to year based on certain guidelines that are given out by various medical organizations and things like that. But sometimes you have to advocate for yourself. So primary care, sometimes now they're a little dissuaded from routinely getting PSAs. They say it's a decision-making thing to have with the patient. So you should know that you want a PSA done. And if you ask, they're not going to really argue with you about that. So that still happens to be the primary test that actually ends up picking up. And if it's elevated, and it could be elevated for multiple reasons, it could be a urinary tract infection. It could be just an enlarged benign prostate, meaning non-cancerous. It could be from certain vigorous activities, such as you might have had a catheter or something put in you recently. So if you have one elevated number, they should probably really repeat it in about 6 weeks to make sure it's accurate, and hopefully maybe avoid some of the things that you might have been doing. Like even certain cyclists who rarely aggressively cycle, and certain bike seats can be pushing up on that area by the prostate. And that can cause certain fluctuations. But the PSA is still kind of the gold standard. There also are some urinary tests now that we've been using that don't base things on PSA, but base it on a couple of genes that are associated with prostate cancer. So that some people that if you have an elevated PSA and before you go getting a biopsy and you want to do something as a secondary test that's not related to PSA, but happens to do with being at a risk for prostate cancer, you could ask for one of the urinary tests that are associated with it. And then there's also different PSA tests, but the main one is just the PSA. There's a prostate health index. It just involves certain type of isoforms, which are different forms of prostate. There's a free and total PSA, but really the main things are the PSA, which is a blood test, and then there's a couple of urinary tests that you can ask for, but that is a little bit more of a question with your insurance, whether or not they'll pay for that. If we do confirm that that PSA is elevated, though, then the next step will be a recommendation on what to do, right? So you want to have that with a rectal examination, which is almost like a big red flag in the minority community, unfortunately. So it's great that the PSA is around, because years ago there was no PSA. It was actually, you just used to feel a man's prostate, and sometimes you felt that it was rock hard, and by that time it's really bad. So because of PSA, we're actually picking up elevations, in which then the exam will actually be normal, but that doesn't necessarily get you off the hook. But you should have a physical examination, which involves a gloved finger with lots of lubrication, and you relax, and it takes about 1 minute or less, not even a minute, a couple of seconds, but just relax and just have it done. So the doctor can feel your prostate. After that, and I kind of stress this because some of our community does not know about this, in that if someone is recommending a biopsy, because the only way to prove someone actually has prostate cancer is to get tissue. As we say in oncology, tissue is the issue. So you have to get a biopsy of things in order to confirm certain things. So in prostate cancer or prostate, if you have an elevated PSA or an irregular digital rectal exam, then it's going to be recommended that you get a biopsy of your prostate. But the advancement of MRIs, magnetic resonance imaging, has gotten better. And you want a high quality MRI, which is called a 3T, 3 Tesla. Because if you go to certain imaging places, they'll do an X-ray test or even an MRI. But if they have one of the older MRIs, it's not the right one to use for this. So your doctor should know all of this. And actually, by this time, you should actually even be seeing the urologist first. You could see them, and then they may send you for the MRI. So they make sure they send someplace where they get it. But anyway, the MRI can show certain areas, both on where we normally biopsy the prostate, because you can't biopsy the whole thing. We normally biopsy what's called the peripheral areas on the outside. But sometimes these MRIs pick up areas of suspicion in the anterior prostate, so that we will actually then biopsy those as targeted biopsy. So if you're going to end up having a biopsy, you want to have it only done once and as best you can. So it's nice to have the MRI to complement, this, that you had elevated blood tests. And they do this, what's called ultrasound guided. They're going to use a probe, which, most are done in the office and you're awake, and people do fine, and you can drive yourself there and home. But if some people are very uncomfortable, they can be done under sedation, but you'll need somebody to take you home, which can be in the surgical center or in the office, in the emergency operating room. And it's an outpatient procedure still. And the ultrasound will go in the rectum, show pictures of your prostate, and then a spring-loaded little biopsy gun will take some biopsies of both the left and right side of your prostate, or some of those targeted areas if you need those biopsies as well. And then when that tissue comes back, the pathologist looks at it, and then there's either prostate cancer or not. And essentially it ranges from what we call grade groupings from 1, which is low aggressiveness and that you actually might be able to observe, and up to grade group 2 to 5, which are a little bit more aggressive. And even some of the 2s you might be able to observe for a while, but the 3, 4s, and 5s, we usually would recommend some type of treatment if indicated.
Thank you for that comprehensive guidance on when men should be getting screened for prostate cancer, but also the ways in which we can determine whether or not prostate cancer is present. I want to merge, if you will, your 2 areas of expertise and talk a bit about erectile dysfunction and prostate cancer. Like you, as a physician, I'm an immunologist, but I get family members who ask me questions about everything. And as it relates to prostate cancer, a lot of my older uncles or other relatives have expressed hesitancy in doing anything dealing with the process because of this notion of not being able to perform after the fact, or erectile dysfunction. Talk a bit about those associations, whether or not they are valid, what people should expect if in fact they are diagnosed with prostate cancer and then go through treatment that's successful? What would a quality of life be for a prostate cancer survivor after the fact?
Well, the first thing I always tell my patients is that, you have to be alive in order to be able to have an erection. So if you have some type of cancer that's being recommended that it gets treated, then the first line for any oncology type of thing is survival. So in urology, we do this thing called the trifecta. So a perfect patient would be somebody that's early diagnosed. You get a treatment, whether it might be surgery or radiation. There's other treatments besides that. There's even what's called focal therapies that can treat half the prostate. And, it just depends on whose eligibility, but it's too much to get into there. But as ties to erectile problems, what it is the majority of people that end up even having some of the issue after the prostate treatment have underlying things to begin with, or a lot of them have erectile dysfunction. So sometimes some people actually are benefiting from it because they've almost had no sex life. They happen to come into prostate cancer, and then there's treatments that actually help even rebuild that ability to get an erection, even if you were treated for prostate cancer or not. More erectile dysfunction is caused by diabetes and hypertension and other non-cancer causes than the cancer. So the main thing, once again, with the cancer is you want survival. That's what you're going for, survival first. And then your quality of life, you can get erections. It will be from anything that you recover to your baseline, to just some pills that can be treated, to there's an injection therapy where we teach you how to inject yourself. There's vacuum pumps that you work externally that help you achieve an erection. And then there's also implants that we put in. And once again, the majority of those treatments are used more so in men that haven't had prostate cancer than in men who have had prostate cancer. So, focus on the cancer and your life expectancy and being around for your loved one, your children, your grandchildren, and the urologists. There's a whole specialty of sexual medicine in urology that deals with that. And they're very happy to see you and get your erection back, or even better.
That's right. That's right. Thank you for that. So we have one question that has come in since we've been on. Can you clarify whether the PSA should be done prior to or after the digital rectal exam? And in addition to that, does the rectal exam elevate the PSA?
Overall, no. So you would have to do a very, very vigorous rectal examination, which is not necessary, to push enough proteins and proteases out of the prostate. And actually, depending on when you got the blood drawn, which probably would have to take at least an hour or more so after that, for it to get into your circulatory system to raise it up. So frankly, most urologists will be seeing patients and we'll do a rectal exam beforehand because just the flow of things, we don't know if you're going to need the PSA test, right? So it goes with it. So no, it should not, just don't worry about that.
Awesome. Thank you for that. So throughout our comments, there have been themes of what is acceptable to men, and even more specifically, what might be acceptable to communities of color as it relates to certain examinations, particularly digital rectal exams, stigma around certain diagnostics that are required for us to have better health outcomes. And in my introductory remarks, I mentioned that men have a lower life expectancy, but that men are also less likely to seek out medical attention than women by more than 50%. And research suggests from a number of different surveys, whether by Harvard or the Cleveland Clinic or other academic research institutions, that one of the main reasons why men's health is much poorer than women's health are around what we refer to as traditional norms of masculinity and ideals of what's manly and what isn't, indications of weakness by having illnesses and debilitations in our bodies and getting those things checked up. And so I want to spend the remainder of our conversation really talking about the root causes that you've seen as a Black man, as a urologist, as somebody who not only has to treat people, but also has to embody this education yourself to keep yourself healthy and well. What are some of the things that you've noticed that make men more likely to not engage the healthcare system? And then how can we overcome those barriers for men so that we can be as whole and as healthy as our women counterparts?
Well, I think that people in relationships oftentimes will seek more health care, and oftentimes they're prodded by their female partners. So hopefully we're in a good relationship. We definitely love and praise our sisters to bringing people in and around. But for men, I think it's just fear of vulnerability, that they're going to hear something that they don't want to hear and go through something. And it's funny because even as they get a little bit older, as a urologist, I hear a lot of men who are in their mid 60s or so, and they're like, well, I've had this little bit of a problem, but I had a good life before. And I'm like, well, you're still supposed to be having a good life. So I don't know what you're talking about. So that concept came from, like, even when I guess they were probably even in their 30s, 40s, and so too, that they just figured that they don't have to go seek any treatment or do anything unless there's a major problem. And I think the main thing is these type of webinars, getting the message out, and once again increasing the representation of the demographics of our country would help. There's more Black and brown doctors, and even ethnicities. I mean, when it comes to, if you think about the Latin community, think about people that are primarily and mostly feel comfortable in speaking Spanish, and they're going to a doctor that's not bilingual and doesn't speak Spanish enough. They can't convey what they want to say. And then you could bring somebody in your family with you, and some of them come in there with their granddaughters, right? So imagine a man's coming in there with their granddaughter. He's not going to be talking about his erectile dysfunction or even certain things that might be bothering them, because they don't want to concern the people that they're with. But I think I think the reliances, and the thing I try to say is I make it about the family and what these people should be expecting and being around for those other ones and their loved ones. And that, just that if you keep in front of these things, that, if your blood pressure is just a little bit high and it's picked up on, then it can be dealt with, hopefully. And actually, you might even find a cause for it that might be reversible, as opposed to you showing up and now having to be on 3 or 4 blood pressure medications and having an end stage like heart failure. If you came in when the blood pressure was just a little bit high, you might have changed your diet, your exercise routine, you might have lost some weight, you might be getting more sleep. There's so many things that can be done the earlier it's dealt with.
Thank you for that. I really identify with your comments around partnership and the significance of women in our lives as it relates to men's health. I remember times where I would host health fairs in communities, and they would be full of women, and all of the women were there requesting information for the men in their life. So much so that we had to implement a service that allowed women to schedule appointments for themselves when they would call to schedule appointments for their husbands or for their brothers. And we would have to say, thank you for calling to schedule these appointments for your loved ones. When was the last time that you have taken the time and opportunity to attend to your own health? And so I would go as far to say that a more engaged male society around healthcare will also result in a healthier female society, because we would be lifting some of that onus, some of that burden off of our women to be mindful of not just their own health, but the health of their loved ones as well. You also just talked a bit about, being 60 or 70 and having a minor issue and speaking to what was and not necessarily being able to look forward to what could be. I recently had a trip with some fraternity brothers. We were celebrating 20 years in our fraternity, and we all sat around and talked about life. And as the physician on the line, I asked my brothers, how often are you all getting physical exams? And to my surprise, very few of them were getting annual physical exams. And we're talking about highly educated men with means who have access to health insurance. One of my fraternity brothers, who is the CEO of one of the fastest growing companies in the country, mentioned having felt this sense of mental fogginess for the last 3 years. And I asked him, well, have you gone to get it checked on? Well, I haven't. I have my family, and I've been spending so much time trying to build my company. And so, this really is a conversation not just relegated to socioeconomic status or education. It really is a cultural phenomenon among men, and particularly men of color, and our lack of engagement around healthcare.
Yeah, there's also, there's a fear, as you know, that goes back to experimentation. So a lot of Black and brown people feel that they might be going to the doctor and they're just getting stuck in pincushions and being used as guinea pigs and just lining the profit for the doctor. So they don't want to go participate in any of that nonsense. I feel fine, type of behavior. But, if your fear happens to be one of, cultural sensitivity, then seek out or find an organization that can help you find somebody that's more like you, because that may just be enough for you to get you there. But if you're, feeling very subjected to racism and other social economic things that are happening, and you happen to only be in an environment where you feel that even walking down the street, someone's throwing the N-word out and all this other stuff, how comfortable are you going to be into going into some office there and trusting somebody to tell you things?
That's absolutely right, which again reaffirms your comments about the importance of diversity among healthcare providers, right? We have the data that suggests that when people are more culturally sensitive and aware, that they provide better care. And I think the feelings around medical mistrust, medical bias, medical abuse historically and presently are valid. And we as healthcare providers have a responsibility to be aware of those legacies and to deliver, if you will, trauma-informed care, which is something we use often in my line of work as it relates to HIV and AIDS. So I think that these are valuable conversations that we're having. We have some questions that are starting to come in.
I'll throw in one other thing real quick in this, that there's a lot of brothers when it comes to the masculinity and things like that don't have any problem going and making a lot of different children with a lot of different women. And as much as some things might be tied into paternal support, it's kind of that same attitude that if you're going to really be a father, then part of being a father and everything is going to be your well-being and health to provide for that child, right? So
absolutely,
that's something else to think about.
Yeah, absolutely. And we could have probably an entirely separate webinar to discuss those dynamics. We have a question from the audience. Besides cost of care, do you have recommendations for healthcare organizations with regards to population health communications or supportive activities and services? Population health communications.
Yeah, so this is more obviously community-based, and I'll say more so for the Black and brown population. If you look at your own ethnic organization or community, like, so particularly for, and it actually is not just for Blacks, but there's a thing called the National Medical Association, and that's I'm the local affiliate president. That's what the Manhattan Central Medical Society is in New York City. But the National Medical Association is an organization that started in 1895. That was a group of Black physicians who were organized around one another to try and help one another and things like that. And that triggers back to, once again, 1895. And the reason was because the American Medical Association didn't allow Black physicians to join, and many hospitals did not allow Black physicians to even have hospital privileges. And that lasted all the way through the 20s, 30s, 40s. And as far as being able to join the American Medical Association, that was only fixed in the late 60s and 70s out of the civil rights movement. So the National Medical Association, I think, is a great resource for anybody, because it's funny, many things that help Black people and patients help everybody, right? So it's a health resource. So if you go on that, its main mission is to try and reduce healthcare disparities. But by reducing healthcare disparities doesn't mean increasing it in the majority. It means just balancing it out. So there's physician resources on there. There's a lot of educational information. So there's information about insurances, information about advocacy and legislation. And so if you look up once again, the National Medical Association, there's the National Hispanic Coalition, there's different organizations that, just click on their healthcare links, and those organizations you feel most comfortable with usually will have a partnership with somebody to give you that information.
Yeah, your comments around the National Medical Association bring up for me a history lesson. A lot of people might not know, historically, many of the organizations in our country that begin with national were formerly Negro. And anything that was deemed American Association, fill in the blank, was an association where Black people were not allowed to participate. And so as we've progressed, you've seen a lot of the organizations that were Negro something, the Negro became national. The acronym didn't change, but the Negro became national. And there's a reason why most of the organizations in our country that have national in front of them are predominantly communities of color. Is because of this legacy of segregation and our inability to integrate into some of these other professional societies. And so just a point of history there as you talk about the National Medical Association and its importance.
Yeah, this whole thing, unfortunately, the game wasn't, it's not even just about our patients, right, not seeking the care. We're so far behind that actually manifested because the fact that people that wanted to be in the profession weren't being treated equally and right. So it's hard to find a Black doctor when Black doctors there aren't as many as we need to be, or even some of us are being, mistreated at times. So, and that's something that, is just not spoken about enough. But, so as the balance creates and the numbers increase, then that's just better. But those are things, and unfortunately, some portions of discrimination and racism that still exist to this day.
Absolutely, absolutely. I think also to the question around public health communications, this concept is more important than it's ever been, especially coming out of the COVID-19 pandemic. I don't think that we did very well communicating public health as a country. And as a result of that, far too many people died when they didn't have to die because of poor communication. And so I think this line of public health is more critical than it's ever been, because we now realize that we can only provide healthcare to people who are willing to participate in it. And so we can have cures, we can have vaccines that are 100% efficacious, but if people don't trust them, if people don't receive the information that they need to be able to participate in those things, then it's useless. And so public health communications are more important than they've ever been. And Dr. McWilliams, we're not necessarily taught in our training how to relate to people. We're not necessarily taught bedside manner. We're taught the X's and O's of medicine and science, and we often treat disease, but we need to move to a place where we treat people and not just disease. And a part of that is how we communicate.
Right. And one other thing I just want to add in too, that one of the biggest things that's way overlooked is that mental health. And that goes from just basics. So that as growing up as a minority in this country creates PTSD, frankly, I think. You're at a society that you're not necessarily always welcome in, and think about all those stressors that are related to things. And this that's a major thing, so that can definitely affect your health as well. So when you go to work, you have different things, relationship with your family. If you don't have a healthy mind, it's hard to have a healthy body. And there's not enough Black and Hispanic patients because of the faux pas and social stigmas that are related, that seek out mental health things. And that's also like just a wellness thing too. It's nothing wrong with seeing a therapist, because everyone has a sad day, just speaking about things, because you cannot talk to even your family or even your best friends about everything. No one knows everything. And these people, are paid specialists to help you deal with those things. So if you think about if you're fighting an ailment or something like that, or God forbid, even have cancer, of course you're going to have mental problems with that. So it's good to seek therapy.
Absolutely, absolutely. As our time finishes, I want to leave our group with an ideal from Frederick Douglass. He quoted, and this was relative to slavery, that it was better to build strong children than to repair broken men. And I think his sentiment is very applicable to our conversation around men's health in terms of teaching our young boys about the importance of their bodies and their health at an early age. I'm a girl dad. I've got 2 daughters. And one of my daughters is a young lady, a teenager. And when she started her cycle, we had a very intentional conversation about her body and what it meant for her and her overall health. And so from a very young age, she has been in tune with paying attention to, responding to what she feels in her body, and being engaged in the healthcare system in ways that I don't remember being engaged as a young boy until I was playing sports and I had to get physicals to be cleared to perform in that way. And so I think that as a society, we would do much better by our boys to start to educate them about their bodies, about the importance of taking care of their bodies at an early age, with hopes that that will carry into their adulthood, so that we don't have to repair broken men, if you will, from the legacies of misinformation and cultural dynamics, but also historical medical abuses around their health. We have one final question. This will be our last question. And then Dr. McWilliams, I will invite you to offer us closing remarks. Given the deficits in practitioners increasing, please share your thoughts on how to assist more people of color with entrance into health care practitioner careers. Excellent question to end our conversation.
Yeah, that's a wonderful question. And there's different programs that are being established and some that even exist already. One thing is there's a program that started by a friend of mine, Dr. Lynn Holden, who works at Montefiore Medical Center and Albert Einstein School of Medicine, but you could look it up online, called Mentoring in Medicine. And they get students in their early, even grade school, but definitely high school and college, and invite them to join this program and follow them all the way through into their hopeful careers. But there's a bunch of pipeline programs in different communities. They have some that we've started in the National Medical Association. Even the American Medical Association, has some of them, but really it's about engaging these students who showing prowess in sciences or just the interest of being into it. One of the things even I'm affiliated with is a thing called SWAG, which is an organization that's actually trying to focus on encouraging student athletes. So a lot of times athletics can be a major distraction, but also a blessing that got people in with scholarships into college. And these students are doing extremely well, or might even just have B averages and stuff, but it's been discounted the fact that how much time they're putting into their sports. But once that's kind of put aside, some of those people go on to be the greatest scientists and physicians afterwards as well. So, and also athletics shows that level of determination and accomplishment. And so if you see a young kid who's a great athlete, focus on their mind as well and say, encourage them with the balance of it all and just say, because they're exceptional. And the fact that they can hone their body to do certain things like that, the mind should be just as hopefully capable.
Absolutely. And we know that only 2% of college athletes go on to actually play professionally. The other 98% go on to excel in other areas of life. And so I think that that is very timely wisdom for that question. One final thought on the causes of stress contributing to cancer and your thoughts on that. We certainly have a significant amount of data that correlates the increase of cortisone levels to other health outcomes, but specifically to cancer. And then I'll ask for you to dovetail your final remarks into your response as we conclude.
Well, no, I mean, the stressors, as you mentioned, have certain type of hormone level changes that essentially stress lowers and weakens your immune system. If you're stressed out, you're going to get a cold even more, or even the flu. So if you're stressed, you're not getting sleep and things like that, and you need a healthy immune system to fight cancer. So the two are very much related. And then once a diagnosis of cancer is given, most people, once again, are going to have some type of stress related. So that's why that whole balance of getting some mental health support, advocacy groups, and reducing the stress, because you can't be stressed out and also be very pessimistic about your outcomes, because that does show in the manifestations on how well people do. So with that, also, I'll thank you all for inviting me. I just want to encourage men that, even if it's just maybe your urologist earlier on in life, to seek some type of primary care, go see a doctor once a year or maybe once every 2 years, get some routine blood work and things like that. And hopefully you'll just be going there and never them telling you that things check out to be fine. Prostate cancer and even erectile dysfunction are not death sentences. And some people, especially in our community, will think that even the erectile dysfunction is worse than prostate cancer because it's more relevant. But whatever it is, whatever gets you there, if you're noticing differences and things like that, having problems maintaining an erection and things like that, those oftentimes can also be a manifestation, because it's the same type of cells that help you get an erection and line certain blood vessels in your penis that line your heart. And that actually might be an indication that you're actually having some heart issues and disease. And so sometimes erectile dysfunction can actually save your life if you're willing to talk about it.
Absolutely. With that, Dr. Glenn, we thank you for your wisdom. We thank you for the time that you have given to us today to talk about men's health during this Men's Health Awareness Month. You dropped a lot of gems for us. If people wanted to keep up with your work, are there places online where folks can access you for future inquiry?
Yes, you can get in touch through the Manhattan Central Medical Society at gmail.com. You don't have to put just Manhattan Central Medical Society at gmail.com.
Excellent. We look forward to continuing the conversation with you. And once again, we thank you for your compassionate service and care.
Thank you. God bless.
Thanks to all of our audience members who have joined us. Thanks for your engagement in the question and answer section and throughout the chat. And we look forward to hosting you again for these Friday NMQF webinars. Take care and be blessed.